Today's video is pattern of visual field defect in specifically in glaucoma, and the last part of the video will be non-glaucomatous visual field defect, and I'll show you pictures only, okay? And I'll try to explain few things, but not in that detail. So let's move. So first, we want to know the anatomy of the nerve fiber layer, because that's crucial when we are going to talk about glaucoma. So nerve fiber layer in the retina is composed of ganglion cell axon cells that is course from ganglion cell body to optic nerve head in a distinct pattern. So basically, optic nerve lies in the 15-degree nasal, and it's slightly superior to the fovea. That's why visual field is exactly 15-degree temporal and slightly lower than the horizontal line. Then the retina temporal to the fovea is divided into superior and inferior half of the horizontal raphe. That's why in case of visual field we see horizontal line, and we compare the upper and the lower part and the mirror part in the case of glaucoma and field test, isn't it? GST. And I'll show you. Okay. The fiber from the nasal half of the retina comes directly to the optic disc as a superior and inferior radiating fiber, isn't it? So if from nasal, it's superior and inferior, but temporal, it's different a little bit. And from the macula area comes horizontally as a papillomacular bundle, and that's what remains until last, isn't it? Papillomacular bundle. And from the temporal retina, fibers arc above and below from macula and the papillomacular bundle as a superior inferior fiber with a horizontal raphe, isn't it? In case of nasal, it comes directly superior and inferior radiating fibers. But in case of temporal, from macula to optic disc, one bundle comes. And what will do temporal and temporal retina, that superior and inferior part actually arcade around that raphe. That's the concept, isn't it? So simple. So let me show you. See, this is the papillomacular bundle, PMB. From nasal, this nasal side, and this is the temporal side. From nasal side doesn't matter. Superior and inferior converges, but this is horizontal raphe. What do we call? From superior, from inferior, just arching around papillomacular bundle, isn't it? And that's what we are talking about. The same thing is here. See, it's blind spot, size of the blind spot. Temporally, you must understand, isn't it? Because of the feeling nasally. From the center of fixation, from center of fixation means here. Can you see? Center is this. And what this from horizontal raphe, something like that, isn't it? And that corresponds here. This horizontal line that matters. This horizontal line is this, something like that. Okay. So just remember this horizontal line in the picture of the retina is this line in the visual field, something like that, which is very important that you can analyze the field of view exactly as retina, okay, and optic nerve eventually. So arrangement of nerve fiber within the optic nerve, those from the periphery part of the retina lies in the deep of the retina. If move from periphery, it lies in the deep part of the retina, but occupies most periphery part of the disc. The farther the ganglion cell, the deeper in the retina and most periphery in the optic disc. While the fibers are radiating closer to the optic nerve head lies superficially on the retina and occupies more central portion in the optic disc. That's matter. More central portion in the optic disc. Disc is different, retina is different. Okay, you know the concept. So the arcuate nerve fiber occupies superior and the inferior temporal portion of optic nerve head and most sensitive to glaucoma status. That's what important point. Those arcuate nerve fiber, superior and inferior temporal part of optic nerve head, and they're most sensitive to glaucoma damage. So account of the early loss is corresponding to regions of visual field. That's why macular fibers are the most resistant to the glaucoma damage and explain the retention of the central visual hill. So what last papillomacular bundle last uh, resist and stays till last. Okay, so glaucoma is visual field defect. So one of the disadvantages of a regular standard perimetry is it appears only 40% of axon loss damaged. Then only you see some defect in visual field test. Okay, so before 40% damage, it's relatively unseen in visual field. Okay, so let's move forward further. Progression in visual field. So what are we actually looking for? Visual field defect is initially observed in Jerem's area. What is Jerem's area? Jerem's area is actually from fixation 10 to 25 degree is Jerem's area, and correlated with optic distance. First you see, it's predicted that first you see something there in Jerem's area, and glaucomatous field takes following sequence. So see, I don't know following sequence. Let me be clear. First two are very uh, unrelevant in case of visual field. Isopter contraction, so peripheral isopter contraction, mild general contraction, central and peripheral visual field, or less visual field, but it's not detected in clinically. So bearing of the blind spot, so exclusion of blind spot from central field, inward curved and bounded in 30 degree and limited for the diagnostic value. This is also diagnostic value limited. So basic thing so most sensitive is horizontal and okay, superior inferior graphic, that is optic nerve head, superior inferior part. So basically there are 8 steps that have been explained. Okay, let me tell you that the very early stage is nasal steps, defect obeying the horizontal meridian. That's where we want nasal step visual field, and that's why we want 27 degree in 24-2, and we have nasal step 2. Second is temporal wedge defect. Okay, I don't know about that. Third is classic arcuate defect, which is comma shaped and extension from the blind. So it's common, it's very common. Fourth is paracentral defect, 10 to 20 degree. Fifth is arcuate defect with a peripheral breakthrough, generalized constriction like a tunnel vision. And the last that resist is temporal sparing, a severe visual field loss. Even central gone, but temporal sparing is there. And finally, glaucoma, yes, total visual field defect. So I'll tell you a gross view and show you some pictures. Okay, so nasal steps is follow the horizontal graphing, and it's projected it's earliest we can diagnose from the nasal step. So arcuate scotoma runs different arc meet the right angle defect in the horizontal meridian. So there is nasal step. Paracentral scotoma is earliest clinical significant visual field defect is paracentral scotoma. It's very important. It may appear above or below the blind spot in 10 to 20 degree from the sixth fixation point, which is definitely Jerem's area, isn't it? So that's called paracentral scotoma. Siddle's scotoma, name itself suggests that paracentral scotoma joins the blind spot from the sickle shaped scotoma. So basically, there's a paracentral scotoma and it joins the blind spot. Then it forms like Siddle's scotoma, which is sickle shape basically. Arcuate scotoma, it makes arc, isn't it? So it's very superior arc, and if you make inferior arc, it's called double arc. It's very simple. Scotoma that starts at the near of blind spot and arches around the fixation point. So there is fixation point somewhere here. So it arches around the fixation point. It actually arches around the fixation point. That's why it's called arcuate scotoma. So abruptly at the basically, so it will abruptly stops at the horizontal raphe because we know the anatomy, isn't it? So that's what arcuate, and double arcuate means arcuate from superior and inferior to. That's simple. So here is the fixation, it arcs from superior. Here is the fixation, it arcs from inferior. That arcuate effect. So in case of advanced glaucoma, visual field loss gradually spreading from center as well as from periphery, leaving behind the small island of central vision and accompanied temporal island left are left. Basically, central vision and temporal is left. Eventually, central is gone and temporal left. Temporal left at, till last. With continued damage, this island of vision also damages and central vision is totally extinguished. And last, temporal island of vision is more resistance and it lost at the end, leaving patient no perception of light. That's how it goes. Okay, glaucoma. So nasal step, temporal ways, paracentral scotoma, and then arcuate, single arcuate. This is the case early superior paracentral defect within 10 degree means basically Jerem's area. So this is where superior fixation threatening paracentral. See sickle shape. This is typical arcuate shape. Is very and advanced tonal and the temporal ways. Finally, tonal gone and temporal remains, and at the end, complete gone. This is the picture with some other than what do you call it, glaucoma. So papilledema, enlarged blind spot. So in case of stroke, this is homonymous, not heteronymous. Homonymous means both left side is gone. This is heteronymous, which is hemianopia is typical in case of pituitary adenoma, bitemporal hemianopia. This is central, left central scotoma, central macular disease. There is a left central, and superior is this. I think it's artifact. So centrocecal scotoma, it's, cecal means it's basically joined to optic disc from center. So centrocecal scotoma, and definitely right this lens rim artifact, centrocecal scotoma, and I have discussed in previous video that's hysteric or malingering case, especially this is spiral visual field defect in definitely not in automatic visual field but in Goldman visual field. So there are few others also. We know this temporal 90-degree inferior is common point. So see arcuate. What are the common differential arcuate? We know optic nerve secondary to glaucoma or AION or papilledema. Sometimes you can see arcuate. It arches, isn't it? Altitudinal defect. So optic neuropathy to ischemic and glaucoma.